will touch on at a high level. So that's the FDA's definition. The rest of the world doesn't quite see it the same way. This is a definition from the European Commission. So the EU regards digital health as use of technologies in care, tools and services, especially focused on information and communication. So you'll see ICT as a term a lot, ICT technologies. And their focus is on what you do with it. So the focus is on prevention, on diagnosis, use of technology for treatment and care, use for monitoring and use for overall management of all health-related issues, and to monitor and manage lifestyle habits, behavior change, things like that that impact health. So we have two very broad definitions that cover most of the world, a large component of the world, but the common core of this is that it's the focus on the use of technologies, especially information-focused technologies, intersecting with patient care, health promotion, disease prevention. The other term that is important to get our arms around for today's conversation is informatics. As with digital health, this is also a very large term, but at the heart of it, the informatics is the science of information. So this definition is presented from the American Medical Informatics Association, the science of how to use the data, how to use the information, and how to use knowledge to improve human health and healthcare service delivery. Applying principles of several different sciences that touch on information. So social sciences, computer science, information science, information management, knowledge management, a whole lot of different components. But we don't stop there because there are 5 recognized subfields of informatics that people think of when they're talking about informatics. The first one that we're focusing on here is clinical informatics, writ large, also referred to as operational informatics or applied clinical informatics. And this is pretty much what it says exactly on the label, which is the use of informatics, the use of digital health, the use of the health IT, the use of technologies in practice to improve healthcare from an operational perspective. Clinical research informatics is looking at the management of the data and the development of new knowledge relating to health and disease. You'll see a lot of this in clinical trials, information management, secondary research uses of data. Consumer health informatics focuses on primarily the patient as the consumer, but really the definition of consumer is also a little broader than that because it can be providers, it can be caregivers, it can be really anybody who has an interest in health, healthcare, health management, public health, and it relates to the use of digital health solutions for health-related and information purposes, right? So this touches very much on patient-provider communication, patient-generated health data collection, data exchange, use of technology for improving health literacy, providing health information. This is where consumer health informatics lives in the space. Public health informatics is a broad population focus. So this is where you see a lot of surveillance activity, health promotion activity, preparedness. And then translational bioinformatics is methods and practices for working with large data sets and working with genomic data and translating that into health insights. The focus of the mHealth and informatics core at Accords is on consumer health informatics, mobile health, which is encompassed in digital health, and applied clinical informatics, so the use of solutions in practice. So as we go forward into the seminar series, that will be the focus on our talks as well. That doesn't mean that there's not a wealth of information about these other areas here on campus. So if you have questions about something like that and you want to know more, still feel free to come to me and I will connect you to people. All right, so with that in mind, I think that everyone can agree that this is a very large field, a very large area. So as we're thinking about technology, thinking of technology in practice, I put up here just a few important milestones when it comes to technology. And the reason that I did this is because just a couple of weeks ago, I had an investigator come to me about a particular project, and they said, I would like to do something, but I don't think my project has anything to do with mobile apps, so it's not digital health. I'm like, okay, we have some education to do because digital health is so much more than that. We actually start all the way back in the 1940s. We're even off this chart. 1940s is when the first work was being done on conceptualization around creating electronic medical records. We finally moved that into the early testing of the first version of EHR in 1965. Even before that, though, we were working with telemedicine and telehealth, radiology exchange, telephonic consults that were audio only, again, in the 40s and in the early 50s. But we're going to stick our pin in the map here for telehealth at the moment of the first video consult, end-to-end real-time video consult, which was done with the University of Nebraska in 1959. We're still learning and growing all of these areas today, but this is where we started. Digital health has been around for a very long time. Following the telehealth track, you'll see that NASA and the Indian Health Service combined in the 1970s to expand telehealth and telemedicine services using technology that was being used to transmit to and from space, to transmit to and from rural areas to provide support to tribal communities and to expand from there. That's the StarPack program. 1970s as well, Epic and Cerner, we moved out of initial development into founding the company to start with EHR system production. Also in the 1970s, we have the very first mobile phone, 1973. It was about that big. It was a brick from Motorola, and it, mobile is a little bit of a stretch there, and considering that was basically a receiver on a brick, but they expanded and went from there. And also the very first thing that we could officially call a smartwatch had a calculator on it in 1979. 1983, congratulations, welcome to the internet. TCP/IP communications protocol was established and information exchange got a lot easier, and then things got a lot more accelerated. So we have Epic Care, the first EHR with that interactive component in 1992. First patient portals, the late 90s, early 2000s, Kaiser Permanente, Beth Israel Deaconess, and again, Epic. The American Recovery and Reinvestment Act and the HITECH Act, which were passed in 2009, included in it policy components to drive the use of electronic medical records. So between 2004 and 2021, EHR adoption overall increased from 20% to 88% of practices. Telehealth continued in its development over all this period of time, but also took a significant jump in early 2020 with the pandemic, when everybody was trying to do healthcare from home. The bottom line here, we're looking again at other forms of like wearable devices and sensors. So the first glucose management CGM system, when the first gen was Dexcom in 2006, just slightly predating the first the iPhone in 2007, followed shortly by the first wearable fitness tracker, thank you Fitbit, in 2010, smartwatches in 2013, 2015. And then here in the 2020s, the number of mobile health apps that are using these types of platforms for solution is over 250,000 currently available. Some estimates put that at 97,000 that are actively used. Some put it at 350,000. Nobody knows exactly how many are active versus were created and released. But the point being, when they say there's an app for that, that's because there really is. And then, while we're talking about transformational milestones, in I believe it was November of 2022, OpenAI launched ChatGPT, and the world started learning about generative AI. And that is also transforming healthcare. So we will talk more about that shortly. So when we're thinking about new technologies and when we're thinking about all this new stuff, and how do we know what's working? How do we know where things are? What is truly emerging, and where what's going to sustain? This particular cycle, the Gartner Group came up with this methodology, and it's been established to hold out fairly well. And so this is the technology hype cycle. So you start on the left-hand side with people getting very excited at the shiny new thing, and that's the point of the technology trigger. And so then everybody starts hearing a lot about it. Everybody wants to incorporate it into their systems and solutions. And then you hit that peak of inflated expectations where everything has become overblown and overhyped. From there, we slide back down into a little closer to reality in the trough of disillusionment. And this is where a lot of solutions get abandoned. People give up on them. Technology companies determine that there's no profit and then there's no reason. Clinicians get frustrated. Patients get frustrated. They stop using things. The ones that come out of that, the ones that sustain, go up this slope of enlightenment into the plateau of productivity. And that is where you have things that are being used in the day-to-day and things that you can reliably depend on. So what does that look like when we're talking about technologies for healthcare? I have emerging technologies published from 2015 to 2024. So we can see a kind of a then and now. For those of you who are on the Zoom, I'm really sorry that I cannot focus in on that anymore. These slides will be available to you if you want to look at that and move in any closer. But just sort of highlighting here, this includes things here on that innovation trigger, on that that upward slope in 2015. Where we're developing human augmentation, brain-computer interfaces, quantum computing, 3D printing of medical technologies, neuro business with the idea that you can control business with your mind, smart advisors, digital dexterity, to improve a number of things there. Machine learning is just over the top of the peak of inflated expectations here and sliding down into the trough of disillusionment. Hybrid cloud computing is all the way down, headed towards the trough. And then coming out the other side, we have a virtual reality, gesture control, being able to control things just by waving at it, which on the Zoom, you can actually see that now when you're gesturing and you have a lot of emoticons going up your screen. The color coding demonstrates the time, anticipating how long it's going to take for something to reach. So something that is, white is anticipated to hit the plateau in 2 years or less. You'll see a lot of things that are orange triangles. That's more than 10 years. So we're predicting the future here with the crystal ball. All right, how do we do? This is the emerging technologies chart from 2024. Going to notice a lot of things are not on that list that were there 10 years ago. And a lot of things that are on here are focusing more based on recent discoveries in recent years. That's one of the interesting things about technology. It is always going to shift and change. And that's why we have a new version of this hype cycle with emerging technologies every year. And so on here, you can see we're looking at coming up the peak, headed to the peak is artificial general intelligence, digital immune systems, digital twinning of customers and patients is something that's coming up the peak. The idea that you can create a digital version of your patient and work with and do diagnostics with and more. And then coming over the top and headed down into the disillusionment space, cloud native, generative AI. Headed just past inflated expectations and down into, maybe this isn't going to be the solution for everything, but it's still important. So just to give you an idea. All right, so if that's all the emerging technologies, what are we currently using? Here are current most common digital health technologies that all of you are very likely to have encountered in your day-to-day life and in your clinical practice and in your research. EHRs and other clinical information systems, data warehouses, data sources. Mobile applications, I mentioned mobile health alone has, over 250,000. I would be very surprised if anybody had not seen one at some point. Wearable devices. Everybody in the room actually gets to do this. How many people are wearing a smartwatch? Another wearable device? All right, over 90% of the room. Environmental sensors. So this is your Alexa, this is your Google Home. These are the things that you talk to. These are the things that are responding to you as you operate and that are reacting according. And social media. Often at this point, when I mention social media as a digital health technology, I get a lot of people giving me very strange looks. They're like, that's why? How is that possibly? Well, I mentioned communication. I mentioned information management. And here is an example of a natural experiment in practice. This emerged at the early stages of the pandemic. 3-star or less reviews left on public sites like Yankee Candle and similar were complaining about how the candles were not as strongly scented anymore. They were able to track that, looking at that data analysis against the first confirmed case of COVID in the United States. And as we know, COVID for some patients has an impact on the ability to smell things. And following these customer review data, they were able to track infection outbreaks and spread of where the virus was proliferating. It's not the first time that we've used social media for viral detection. Flu season every year posts about not only for vaccine hesitancy, but also for tracking patterns. CDC has used it for foodborne illness outbreak discernment, people complaining about getting sick after eating at certain restaurants, things along those lines. Don't underestimate the power of social media. All right, so we've talked a little bit about the technologies themselves. We've talked a little bit about the broad concept of digital health and applied clinical informatics. So what are some examples of places where we can actually use technology effectively? This is not a comprehensive list because we have 1 hour for today's discussion, not an entire course or the entire year. But these are high-level things that are very, very commonly using technology solutions for. To help reduce administrative burden, to help connect communities and providers and can bring healthcare closer together. For decision support, predictive analytics, managing all different types of chronic conditions, remote patient monitoring, patient-provider communication, patient education, and support. So what do I mean when I say these? Again, not a comprehensive list, but just high levels of example. So looking at administrative burden. One of the things that every clinician that I know always complains about when I suggest that maybe there's a technology that can help them with something is that they don't want the technology to do anything else because they already have to spend too much time in the EHR documenting or clicking things or following things, and that it has affected the practice of medicine because it is adding so much work. Well, technology has caused a problem. Technology has also heard and understood that there needs to be a solution for it. So an example of a solution that is looking at a possible way to address this is the use of artificially intelligent ambient scribes that listen to the conversations between patients and providers and attempt to create summaries of that for the provider to review and to aid with medical documentation. So this is a summary of a particular result that they trialed this over, I believe it was 10 weeks since implementing this. It assisted over 3,000 physicians and in over 300,000 patient encounters across specialties and locations. And the response from people who used this ambient scribe service was overwhelmingly favorable. They found it helpful. This is an area, there are several people and several companies in this space attempting to grow this just because of this overwhelming need and the fact that it apparently is working well. Connecting communities to providers. So focusing on telehealth and telemedicine. Right now in the United States, I think 30% of rural hospitals are in danger of closing. There are only 5 states in the nation that don't have at least one hospital at risk. There are many areas where certain types of specialists are simply not available. In the town where I grew up in rural Tennessee, cardiology services were available once a week with a mobile clinic to members of the town. And if you needed care beyond that and that primary care could not give you, you had to go minimum of 2.5 hours to Nashville, Tennessee, and hope that you were able to get the care that you needed. People got health insurance for flight to life so that they could get helicopter rides to the hospital rather than trusting that they would be able to get there. Not alone. Here in Colorado, there are places where there are no OBGYNs, no no cardiologists, no other specialties. A lot of these people are being served by clinicians here on the medical campus through telehealth and through e-consultation. So we looked at this particular, reduction of, it's an alternative to driving into the medical campus over, multiple hours of time. We looked at also the climate impact of it as an example, and found that by using e-consults and telehealth over the course of 2019 to 2022, I believe, saved 310,000 miles, 13,000 gallons of gas, over $56,000 in savings, just from avoided expenditures, not to mention the travel time saved was 5,500 hours. So technology can help in unexpected ways. Clinical decision support. There's so many ways to do clinical decision support and to support it through a variety of technology solutions. I am just going to highlight one example here on campus, Colorado Program for Patient-Centered Decisions using decision aids. So they have on their website, they have a list of a variety of decision aids that are available in a variety of formats. So looking at the decision aid for ICD alone, there's booklets, videos, and multiple languages, encounter-based tools, as well as educational tools provided. Or if you don't want the digital component at the very bottom, you can actually get a paper copy as well. Just one example. Chronic condition management and patient-provider communication, wearable devices, smartphone applications, patient-generated health data, things that are collecting information that are helping with patient self-efficacy in logging data, in tracking information, in bringing that to their providers. Some of them bring it in by bringing the phone in to show. Some of them send reports. Some of them are systems that are connected and collected with the EHR to do real-time transmission. Remote patient monitoring. This means a lot of things at the high level. It's the use of technology to help keep track of what's going on with your patient between visits. So telehealth and remote patient monitoring. You can use solutions in practice to connect over telehealth systems. A recent project here on campus, and related to a project that was actually taking place in the Northeast. Our teams didn't know each other, but we're working on it independently at the same time, is using biometric monitoring and interactive chat solutions to keep track of people immediately after bone marrow transplant and CAR T-cell therapy to attempt to avoid febrile neutropenia, neurotoxicity, and infection. Developing and scaling using other devices in ambulatory practice to collect information between visits, so that in that 20-minute primary care visit, you're not trying to cover everything from scratch, but you can work with information that was collected from outside and summarized. And then also bringing the hospital to home and using technology to support people being able to be earlier discharged from hospital settings and recover safely in home environments. Safely is key. Safely is also achievable. Predictive analytics and personalized medicine. If you haven't read this book, I highly recommend it. Deep Medicine by Eric Topol, talking about potential transformative power of AI in healthcare to make it more human. But focusing on that, and again, sort of tying in with the patient-provider communication, patient education and support. The idea here is not that AI and not that any of these tools would replace a clinician. They will augment and support. There are some things that it looks like the technology is learning how to do well. This paper came out in April 2023, looking at in a public forum responses by actual clinicians and an AI chatbot to patient questions. And the patients found that the chatbot was kinder and that the provider was busy. Providers also tend to like the language and the processing of artificial technologies. So this one is from July of this year, published in JAMA Open, a large language model-based responses to in-basket messages. And they found that the the artificial analytics and crafted responses to the messages were more comprehensive and thoughtful than those that were being crafted by healthcare professionals, which I think tells us that our healthcare professionals may have a lot of burden. Maybe this is an area where something can help. That said, technology is great. Technology is wonderful. We love technology. There are some problems. And there are some considerations. And there are some challenges. Because these are tools, and tools are only as good as their design, and tools are only as good as how well they are implemented. So I'm, again, not this, we could be here all day, but so I'm just going to do a high-level review of some of the more common ones. Starting off with the digital divide. So what this term means is it's referring to primarily differential access between groups to broadband internet. So high-speed internet and everything the internet brings with it, everything that requires an online connection, everything that requires bandwidth, downloading, speed, always-on connectivity. There are areas in this country where that flat out does not exist. There are people in this country and globally, this is not limited to the US only, where the infrastructure is not there, where cost is a factor, where access to the devices is a factor, where the technology literacy to use them effectively is a factor. This co-occurs with other population characteristics that are particularly representative of people who are already experiencing high burdens of health inequity and health disparity and are underrepresented in medicine in a variety of ways. Older people, age is a significant factor. I mentioned geographic location already, socioeconomic status. Language, race, and ethnicity is a factor here. Primary language, I mentioned those 350,000 mobile apps. How many of them are in languages other than English? Very few. How many of them are in languages other than English and Spanish? It's not good. And a lot of the newest technologies start out in English because that's the easiest to develop and get abandoned if there's not enough of a return. Not only that, cultural adaptation is missing, and we'll talk a little bit more about that as well. But not one size fits all, and that is very true with technology. So as I tell researchers all the time, you need to make sure that when you're implementing solutions in practice and when you're creating new ones, that you're not building on something that was only created by white guys in Silicon Valley. Technology solution, not useful if no one uses it. Another way to think about adoption and engagement with the technologies, and this ties in very closely with what I just mentioned about the digital divide, is this spectrum, this bell curve, this distribution of who is likely to be using the technology. This is Rogers' diffusion of innovations distribution. It was originally developed as a framework and a model, a theoretical approach for agriculture, but it turns out to be particularly applicable to technology adoption. So over here on the far left, you have 2.5% of your population are your innovators. Then these are the people who are cutting edge, bleeding edge. Early adopters are the ones who are going to wait, but they're not quite first in line at the store, but they're going to get it in the first 6 months of the year. Early majority this is where most of your technology using people, the general population, is going to fall once something has proven out and people are comfortable with it. Late majority, these are the people who have to be a little bit more pushed into it for whatever reason, or who maybe don't have the disposable income to be investing in the latest technologies right off the bat. And then we have laggards who are, these are your tech avoidant, but these are also the people who don't have access for whatever reason. Policy and regulatory issues are also critically important to consider when you're thinking about technologies in research and in practice. Here is just a very brief list of the policy and regulatory considerations. HIPAA, GDPR is the European equivalent for data privacy, security, protection, safety. GDPR is particularly interesting because it includes something called the right to be forgotten. And what that means is that if you have a technology solution and you are collecting data and information for healthcare purposes, and your patient says, you know what, I don't want you to have that information, go ahead and forget me. Okay. You have to not only delete them from your system, but you have to delete everything that has been stored all the way back to the beginning. Now take a second and imagine the impact of that on electronic health record, on the systems and the infrastructure that go into dealing with it, on the integrity of a research data set. Data storage, health data exchange. There are certain projects and products and solutions that are required to be hosted on servers in the United States. We've had investigators that have come to us and realized, I was doing this research with my partner, but their server is in Ukraine. I'm like, okay, that's going to be a problem. The backups in Ireland, still a problem. So sorting out things like this early is very, very important. I mentioned the FDA before. EMA is the European equivalent of that. Other regulatory agencies that oversee digital health and technology solutions when used for health and healthcare. The FD&C Act is the one that gives the FDA the right to do that. FTC is for communication, CAN spam. So this is, all of the text messages that you get from people on your phone. Has anybody noticed a drop in that when it's health related in recent years? Recent months even? Colorado has passed a law that you have to get affirmative consent from people to engage with them with tech-based methods. It's building on the national law, the CAN spam, which the violation of that and violation of HIPAA, if you're attempting to exchange protected health information over unsecure, is a $50,000 fine per instance. And when I say per instance, I mean per text message, for example. So these are considerations that you have to keep in mind. And then also the tech makers, their interests, their technologies, their software, hardware, user licensing, and considerations like that all have to go into mind when you're considering for research and practice. Data quality, security, and ownership. Again, that conflict of interest with the tech makers is what prompts me to this, because the ownership of the data. Who owns the data? Does the patient own their own data if they're sharing it through tech? Does the technology manufacturer and vendor own the data or own the right to use the data because it's coming through their solution? Does the health system own the data or the data set that's being stored? All of these questions have no certain answers yet, but the value of data for analytics and for extended insights and for care is increasing. And so this is becoming more and more important as consideration. I touched on ethics and equity earlier, but we're coming back to that because it is a bigger concern, I think, than people realize, unless you are deeply embedded in this. So this paper that I'm showing here, this example was published looking at what they're calling experimental evidence of massive scale emotional contagion for social networks. What that means is that they went to Facebook and they asked Facebook, this is some years ago, to change the way the feed presented information to people that were, reviewing and engaging with their social media. Some people's feeds gave them only bad news and negative outcomes. Some people's feeds hid that, and they found that as they were doing that, there was a contagion. The more bad news you read, the more stress you got, the more negative your outlook on the world became. Sounds like interesting and important information to know, right? Absolutely. Problem is they never notified the people they were doing this to. They did not do any consent. They did not do any follow-up to address any emotional or mental harm that might have been caused. We're talking a lot about the power of AI. This paper is looking at how feasible is it to combine all these large data sets. We spend so much time protecting patient privacy. What they found out is that combining like multiple large data sets and multiple studies, you can re-identify people from them. Even if you're stripping the identifiers one place or another, The power of the analytics is such that re-identification is a lot easier than it used to be. Talking a little bit about generative AI, now I'm looking at the visual version of that. So these are all real examples that I myself have seen. Go to the visual models and ask generative AI to give you a picture of a medical doctor. They're all white guys wearing coats and stethoscopes. There are no women. There are no people of color. Ask for a flight attendant. Old style stewardess pictures. Ask for an image of a person with autism. They all have come straight off of Big Bang Theory, and they're all thin white guys with dark hair who are fairly young. The data is only as good as what underlies it. The human biases are included in the tech, in the design, in the results. We, as clinicians, as researchers, have to be aware of that so that we can address it and make sure that the things that we are creating are high quality, are reliable, are equitable. And it's really important because right now it's killing people. So this is from Health Affairs, looking at, it's a very provocative headline, right? Medical algorithms are failing communities of color. So we looked a little bit deeper into, what exactly do they mean by that? So here's a specific example. Black Americans are 4 times more likely to have kidney failure. The algorithms that were being used to recommend, not only diagnosis, but recommending for transplant were far less likely to recommend Black patients for kidney transplant than white patients, even when every other factor was identical. Similar algorithm look at in science for looking at racial bias, found that, and this algorithm, very widely used for assigning level of risk for recommending care solutions and insurance coverage for same, was looking at cost data and estimated that they found that racial bias was reducing number of Black patients who were being identified and approved to receive recommended extra care based on their illness levels, less than half what it should be, because of inequities in access to care and considerations of cost, things along those lines. The data underpinning it, they thought, oh, Black people are not as sick, therefore they don't need as much care. Wrong interpretation that costs lives. Misinformation, disinformation, challenges here. People talk all the time about asking Dr. Google, which is not a good thing to do, about getting information from, the Facebook group from my aunt, or TikTok had a video on how to do this, or, I saw this on X or Twitter or other forms of social media. The icon at the bottom here, for anybody who doesn't know, that's a ChatGPT. Different examples, people started asking ChatGPT health-related questions, which, okay. So how good is ChatGPT at things? This particular study was looking at assessing the utility through the entire clinical workflow. Overall accuracy of almost 72%. Highest performance in file diagnosis, 3/4 of the time it got it right. 60% for initial differential diagnosis. A little bit of learning. A little bit of learning needed. Can't quite trust the tech to do the job of the person without guidance. And then there's disinformation. So I am disappointed to have to report that this is a Reuters journalistic investigation that found during COVID an anti-vax campaign to attempt to promote not getting vaccines that were made in China. And what is incredibly unfortunate and awful about this is that this was targeted at the Philippines. Here's an example of one of the messages, for the language that you can see here, warning Filipino people not to get vaccinated because the available vaccine is from China. People died as a result of this disinformation, this misinformation. Trust in vaccines, trust in the system was reduced. The knock-on effects of that, not great. Technology is incredibly powerful, and in that power lies danger if used poorly. And then finally, sustainability, just to touch on that a little bit. This is the original paper by Gordon Moore, no relation, from 1965. He worked at Intel and he did some analysis and some predictions identifying that the ability of a computer chip would double in capacity every 2 years. He thought that prediction would last for a little while. It's still accurate today. The pace of technology development is such that the turnover in new technologies every 18 months, every 2 years. What's the quote about how long it takes to translate research into practice? 17 years. A little bit of a disconnect there in how to make something sustainable and how to get it into practice. So we can help you do that. We can help you address some of these questions. Over the course of the next 6 months, we'll be having a deeper dive talks in some of these areas that I've highlighted today for consideration to go deeper into the issues, but also into potential solutions and ways to address them in your work, in your practice. We provide through Accords, through the Mobile Health and Informatics Research Methods Core, we provide methodological support. We also connect you to other people who are doing the same thing. And for every investigator who has ever asked me if we know anybody that can help them build the solution, yes, we do. We can help connect you to technical development, user-centered design, experience testing, and methods for research and practice. So I hope that this has been at least an interesting overview today, and I hope that you've heard something new, that you've broadened your horizons a little bit and has whetted your interest for more in digital health. And we'll take questions.
Start with questions here in the room. Anybody want to jump in first and raise a hand? All right here in front. Go ahead.
When you talked about all the different types of PhDs,
yes,
there were some that were kind of bespoke and specific to health, and then some that were repurposed social media posts.
Yes.
I guess in your framework for what are the most reliable, it seems to me that bespoke solutions are probably going to be best, but probably at a higher cost versus the secondary data from other. So I'm kind of curious, what's your perspective in terms of where on some of these journey with digital health technologies and utilizing them, or places to start versus places to go.
Your question is as big as the field. Thank you for that. No, you're absolutely right. It's to the extent that you can custom make something or custom tailor it or custom refine it. A lot of the time you're going to be able to get exactly what you want from that solution to do it. With technology, most of the time that will be the case, but not comprehensively, because the cost of development is a factor and the cost of sustainability and dissemination more broadly. So maybe for a particular example, I'm going to focus on text messages as a technology that's being used in ways that it was never originally intended. Text messages actually were originally created using the channel, which is just a little component of the telephone bandwidth channel that was used to identify technical problems with the infrastructure and the bandwidth. Short burst messages that could get through when nothing else could. So they started using it for all of the other things that you wanted to get through when nothing else could. And then as people started relying on it more as reliable communication, quick bursts, brief messages, easier to adopt, easier to internalize. The health system originally fought against using text messages for health promotion, disease prevention purposes, because they perceived it not to be secure enough. Similar challenges with email versus fax, but that's another story. And so originally was insisting third-party encrypted applications only to send messages through that, rather than any sort of health data, health information exchange, health promotion. Custom created, absolutely perfect for its intended use. Not widely adopted. So it's a balance. The short answer, I guess, is that it is a balance in between the specific needs of the community you're serving versus the broader reach and longer term sustainability. And there are some specific things that you can look at with technologies that we can help you find.
Thank you. I had another question in the back of the room. If you speak real loud, we might be able to hear it. Otherwise,
Otherwise, we'll repeat it. Yes, sorry. Yes. Yes.
But at the same time, I was listening to your presentation, I couldn't help but wonder the human factor that patients
Yes.
obtain, the value of human factors when you are face to face with a practitioner and they're listening to you and your facial expressions and everything. So I was wondering if you have any information on overall patient satisfaction and how that influenced their engagement and follow-up with treatment.
That's such an important question. Okay, for the benefit of people on Zoom, the question is about the power of the use of technology in patient and provider interactions with patients, but also does that interfere with the human factors, with the ability to have a conversation, to see people's expressions, things along those lines. How, what is the trade-off there? And it's such a critical question because technology is a tool. Technology is not a replacement for the provider and for that patient-provider interaction. Where technology can be particularly powerful is in collecting, in synthesizing, and bringing in data that otherwise would have to be manually discerned bit by bit. So bringing those summaries, either sending them to providers in advance or bringing them into those conversations, augmenting the power of the electronic medical record, allowing patients to be able to keep track of their own information when their doctor isn't available, when it's difficult for them to reach, for them to get in for a visit, for when they're waiting for a response to come back. If they have a reliable source that they can look to that can provide them, or they have data about themselves. Specific example of technology doing something that helped the provider was a use case of a patient at home having a lot of trouble breathing, having trouble walking across the room, thought that they had asthma, so they thought it was just a bad flare, until their Fitbit started going off every 5 minutes, warning them that their heart rate was 220 and sustaining at 220. So they called the doctor. The doctor said, please go to the ER now. and they received the cardiac care that they needed before they had a heart attack in the home. But the technology helped give them the information so they could ask the pertinent question. But the interaction with the clinician is a critical and absolutely valuable part of that. And we do see studies where if you're staring at the screen versus your patient, if you're looking at your tablet or your phone versus your patient, patients notice that, and that makes them feel disconnected. Conversely, if the technology is approved by the providers, then the patients feel that they're interacting with that, they're still interacting with their providers. We have a research example of closed loop communication, automated, again, text messages, automated text messages, closing the loop, sending a thank you message for patients sending in a blood sugar value. And in the follow-up of that, patients were very excited that they got the thank you message because they knew that their doctor was reading the messages, that they knew that their physician was watching over them, that they felt more cared for by their provider because of that interactive, simple exchange that the tech was doing. And they knew the tech was doing it. Other questions?
Yeah, we have a question from the chat, and I'm going to sort of summarize and shove it into a new format. But I'm wondering if you can comment on all the things you just shared and sort of the speed of development in the space and how that fits with our research and funding cycles, and particularly the phenomenon wherein many of the things we might want to look at in digital health are obsolete before we can get funding and then actually conduct the study and write it up. So I'm curious how you've navigated that, and also just your thoughts on how to sort of what that all means for
really
researching digital health.
It's an important question, and it's important for a couple of reasons. One of the things is funding, the funding question of how do you get funding to develop a new technology solution to build the infrastructure. So NIH and AHRQ used to give you funding for that. They're a lot less likely to now because of the pace of abandonment and the speed at which investment in the tech industry is outpacing some of the research development. The application in practice, the applied clinical informatics, the use of digital health solutions in practice to drive a need and to look at the behavior change, to look at the impact on health outcomes, is one way from a funding cycle to position that. It is very possible to write your grants, in particular, giving examples of the type of technology, and to acknowledge that partway through you will evaluate and evolve, and rather than hanging everything on a single point solution and get there. Another possibility that we have had significant success is working with industry partners who are interested in helping to develop new ideas or helping to test them, or that have products of their own, but they don't have access to patients, but they're very interested in having clinical validation of their solutions. They're also okay with hearing no, that it doesn't work, because that tells them where they need to pivot and adapt. And we have, I have investigators, and I myself have worked with companies from, two people on a computer, company size, to multinational global entities to support technology research and evaluation that helps try some of the new technologies, and then you can go beyond there. So there's multiple ways, and we have a variety of options.
Well, thank you.
If anybody had questions that didn't get answered, feel free to send them to me. Thank you for being here today. I'm stepping out of the way. Sarah.
No, Susan did my job for me. Thank you all for being here in the room and on Zoom. And we hope to see you at the next iteration of our series in October. And thank you all.
Only LinkedIn. Your ex.